Hello everyone. Welcome back to the channel. Today, we're going to discuss one of the most important topics in modern intensive care medicine, newer antibiotics in critical care. With the rapid rise of multidrug-resistant organisms, especially carbapenem-resistant enterobacterals, CRE, multidrug-resistant Pseudomonas aeruginosa, and Acinetobacter baumannii, the antibiotic armamentarium has expanded significantly over the past decade. Several novel beta-lactam, beta-lactamase inhibitor combinations and siderophore cephalosporins have transformed the management of resistant gram-negative infections. In this video, we'll review why these newer antibiotics were developed, their spectrum of activity, when to use each agent, important limitations, and practical ICU tips. Let's begin. ICU patients have multiple risk factors for antimicrobial resistance. For example, mechanical ventilation, central venous catheters, prior antibiotic exposure, prolonged hospitalization, and immunosuppression. Unfortunately, traditional antibiotics like carbapenems are becoming ineffective because bacteria produce enzymes called carbapenemases. These include KPC, OXA48, NDM, VIM, and IMP. Different antibiotics inhibit different carbapenemases. Understanding this is the key to choosing the correct drug. Most newer antibiotics belong to 5 groups. 1. Ceftazidime-Avibactam. 2. Meropenem-vaborbactam. 3. Imipenem-cilastatin-relebactam. 4. Cefiderocol. 5. Sulbactam-Durlobactam. There are other newer antibiotics as well. However, in ICU practice, these are most important. This is probably the most widely used newer antibiotic. Active against KPC and OXA48. Excellent against many ESBL-producing enterobacterals. Also active against many resistant Pseudomonas strains. Not active against NDM-producing organisms. Remember, avibactam does not inhibit metallo-beta-lactamases. ICU indications: septic shock, CRE bacteremia, HIP or VP, intra-abdominal infection, and complicated UTI. Often considered first-line therapy for KPC-producing CRE infections. Think of this drug as the KPC specialist. Excellent activity against KPC-producing carbapenem-resistant enterobacterals. Very reliable for bloodstream infection, complicated UTI, hospital-acquired pneumonia. Not useful against NDM, OXA48, and Acinetobacter. This combination restores activity against resistant organisms. Good activity against KPC and resistant Pseudomonas. Useful in hospital-acquired pneumonia, ventilator-associated pneumonia, septic shock, and complicated UTI. Not active against New Delhi metallo-beta-lactamase. Acinetobacter. This is probably the most fascinating antibiotic. It is called siderophore cephalosporin. How does it work? Normally, bacteria actively import iron. Cefiderocol attaches itself to iron. The bacteria unknowingly transport the drug inside. This is why it is nicknamed the Trojan horse antibiotic. excellent activity against Carbapenem-resistant Pseudomonas, Carbapenem-resistant Acinetobacter, Stenotrophomonas multifida, and many NDM-producing organisms. This makes Cefiderocol unique because it retains activity against many metallo-beta-lactamase producers where other beta-lactam-beta-lactamase inhibitor combinations fail. However, some studies have raised concerns about higher mortality in certain Acinetobacter infections, so careful patient selection and antimicrobial stewardship are essential. This is the newest major advance against Carbapenem-resistant Acinetobacter baumannii, CRAB. Remember, Sulbactam itself has intrinsic activity against Acinetobacter. Durlobactam protects Sulbactam from degradation. This combination has shown improved outcomes compared with older polymyxin-based regimens and is becoming an important option for CRAB infections. We will discuss apart from these 5 major antibiotics, Ceftolozane-tazobactam. This is an excellent drug for multidrug-resistant Pseudomonas aeruginosa. Less reliable against Carbapenem-resistant Enterobacterales. Think it as Pseudomonas specialist. Very useful in ventilator-associated pneumonia, complicated UTI, and intra-abdominal infection. New antibiotics should not replace good antimicrobial stewardship. Before prescribing, obtain cultures. Identify resistance mechanisms whenever possible. Use rapid molecular diagnostics if available. Optimize pharmacokinetics by using prolonged or continuous beta-lactam infusions when appropriate in critically ill patients. De-escalate therapy once susceptibility results become available. Current ICU guidance emphasizes matching therapy to the patient's risk of resistant pathogens, using appropriate dosing strategies, and de-escalating promptly to reduce further resistance. Carbapenemase coverage. 4 KPC producing CRE infections, Ceftazidime-Avibactam, Meropenem-vaborbactam, Imipenem-cilastatin-relebactam. 4 OX48 producing CRE infections, Ceftazidime-Avibactam. For NDM producing resistant organisms, Cefiderocol or Ceftazidime-Avibactam combined with aztreonam in selected settings. For infections due to CRAB, Sulbactam-Durlobactam or Cefiderocol, depending on susceptibility and local guidance. The future of ICU antimicrobial therapy is moving toward rapid molecular diagnostics, precision antimicrobial selection, therapeutic drug monitoring, AI-assisted stewardship, and continued development of agents targeting World Health Organization priority pathogens, although the antibiotic pipeline remains limited. To summarize, understand the resistance mechanism before selecting a newer antibiotic. Avoid using these agents empirically unless there is a high likelihood of multidrug-resistant pathogens. Always obtain cultures and de-escalate therapy whenever possible. Combine newer antibiotics with strong antimicrobial stewardship to preserve their effectiveness. If you found this video useful, please like, share, and subscribe to the channel. Let me know in the comments which critical care antibiotic topic you'd like to see next. Thank you for watching, and I'll see you in the next video.